This is Eric. You are a cardiologist, a geneticist, a teacher, a geek, a entrepreneur. But one of the things that I wanted to talk to you about, and an author, I should mention, the creative destruction of medicine. One of the things that I wanted to talk about right at the outset, since Craig was just talking about this, you were one of the first people, or among the first cohort of physicians, practicing physicians, to recognize that there was this turn in the way genetics was used. So the traditional use of genetics in medicine was these kind of tests for deterministic conditions. And that's the classic kind of genetic test that we give mothers or expectant mothers or newborns. But you recognize that there was what the genetics that Craig was working on created a different kind of engagement for patients and physicians with their DNA. And I wanted to see if, I want to ask you basically, was there a light bulb moment for you when you kind of realized that there was a way of integrating the genetic stuff that Craig was doing into your practice?
Well, it really was actualizing the potential for the public, consumers, that just wasn't just only a research play, that in fact a lot of this information could be useful, and I actually would maintain that it is. It's all part of this digitizing human being theme, yeah. Whereby people who know their DNA, first these common variants, and then as we go on with more sequencing, the low frequency rare variants, that'll become much more granular. We'll have much more probabilistic information about what each person's liabilities are. But early on, we did a study with a consumer genomics company, Nanosensors, like 23andMe and others, that are really catering to getting this data out to the public. I think it's terrific, and we did a study in a few thousand people that showed that they cope very well with this information, and in many cases it was highly actionable in terms of getting the right screening, in terms of avoiding sun, all sorts of things that whether it was diabetes or colon cancer, it brought to the fore important information about their potential susceptibilities.
So it's actionable for patients to change their lives, make different decisions based on their genetics. Who's responsible for that in kind of the current healthcare system? Who's responsible for saying, okay, let's do a test, or I am going to do a test? Where does that responsibility lie?
We're in a pretty tricky time right now because the American Medical Association, for example, is lobbying the government that people shouldn't have direct access. They should actually have to go through a doctor or a genetic counselor. The latter doesn't make much sense. There's only 3,000 genetic counselors for 310 million people in this country.
Right.
So that's not going to work. As far as the physicians, we know from surveys that the AMA did that only less than 10% have any comfort level in interpreting this data or using it. So that's why I think it's really important that this is driven by consumers. And it's admittedly, the information we have today is somewhat limited, but it's still, in many individuals, it's highly worthwhile, and it's just going to get better and better over time. And I think that's a right of each individual. They want to have access to their DNA data. This should be fully democratized. And so we're going through a tough time right now because governmental agencies have been basically working against that theme, and I don't think it's a good idea.
So the kind of most familiar way of talking about this is pharmacogenomics, the idea of tailoring drugs to people's genome, which always seemed like it was going to happen sometime in the future. But we were talking about the FDA has a list right now that's available on the website where there are 120, 130 drugs that right now have specific genetic interactions. So that list is there, but what? So you did Plavix, I think, is some of the work that you did specifically on that drug that has specific interactions. I know that I have the mutation or the variation that makes me, basically, it doesn't work for me. That drug doesn't work for me. But unless I had my 23andMe test, I wouldn't know. So that list, who's kind of making that list, bringing that into the clinic?
Well, right now, it's just sitting dormant. It's really unfortunate. And there's only select centers that are using select bits of this pharmacogenomic rich data. So whether it's Plavix, now generic clopidogrel, or whether it's interferon for treating hepatitis C, whether it's Tegretol, carbamazepine, which is used for a variety of neurologic disorders and has a potentially fatal side effect that could be screened, but not in this country, only in Taiwan, where you have to have a genotype before you can get that prescription filled. That's a uniform policy. So we're not.
Wait, explain that, because
Yeah.
so in Taiwan they do a test. They have a kind of it's by the law, right?
It's by law.
So
and so the 1 in 1,000 people that take Tegretol, carbamazepine, who could get Stevens-Johnson syndrome and die, that's screened out by doing genotypes.
Stevens-Johnson syndrome is not where you go and write books about the invention of air and stuff.
No, that's a different Stevens-Johnson on innovation. This one is a horrendous immune-mediated from even just one pill, skin reaction that 1 out of 4 people die from. So we just basically give the drug. We know the allele and European ancestry in this country, but we do nothing about it. And it's just one of many examples on the list, but not being actualized in medical care of patients.
So how are you so you run the Translational Research Institute at Scripps, but you also have a clinical practice there. How are you and how is Scripps introducing this information?
Well, we're trying to get a lot of these things into the real world of everyday care. So we did back in 2009 start the Plavix story.
Right.
Anyone who's having a stent gets a genotype to see whether they'll respond. Since 1 out of 3 people carry a loss of function allele, it doesn't allow them to metabolize the drug, which is basically inactive. It's like taking a placebo. So that's a pretty big problem, which we can screen out and then work with either higher doses of the drug, which in some people can override, or switch to other new drugs, which bypass the problem. And then we have also instituted the interferon screening, because half the people for hepatitis C who get pegylated interferon are not going to respond, and you can predict that very accurately with a simple genotype, IL-28B. But now we'd like to roll this out for things like metformin, statins for the muscle reaction, the severe muscle reaction, and many others that we have the knowledge, but we're not using it, which is really unfortunate.
Right, and so this is some of the research that you're doing at Scripps is built to making these, kind of pushing this thing forward. The one that we talked about that I think is immediately relevant is the DNA electronics project.
Right.
Can you explain that one?
Yeah, so one of the barriers here is not just lack of the knowledge, but making it practical. Because if you do the genotype and it takes a week to come back, it's kind of out of sight, out of mind, and maybe a different physician, all kinds of things that can get in the way. So now if we can do this at point of care in 20 minutes or even down to 10 minutes, that's what we're working with right now with the company DNA Electronics
Point of care
in the UK.
genotyping.
And what we're hoping to do very soon is to get that in local pharmacies. They're actually really keen on it because the pharmacist can do the cheek swab, do the genotype that's relevant, and then the consumer can shop 15 minutes in the store, in the drugstore, which they like. But in the meantime, we can match up the right person with the right drug, right dose sort of thing, and that, I think, would be a big advance.
Right there. So the other big piece of research that you're doing, so there's all this genetics, and we'll get back to the genetic stuff. But you also have this the Institute for I'm trying to get the sensor center that you have. And you've got a recent grant from just a couple weeks ago from Qualcomm to do research basically connecting sensors to the medical clinic and information. And I want to help people understand that, kind of where again, you're kind of taking this future that we were hearing about yesterday from Gary and Kevin about quantified self, and you're actually bringing it into the clinic right now.
Right. So this is Scripps Digital Medicine, and
that's it.
As you mentioned, Thomas, we got a great grant from the Qualcomm Foundation.
Right.
And that's
important distinction.
Yeah, foster and accelerate some of these projects. One of the ones that's a little more futuristic is the nanosensor that's put into the blood to couple with genomic signatures. So we're trying to not predict heart attacks, as was mentioned yesterday, with respect to who might get one sometime in their life, but actually temporally know that within days, that between the sensor that's in the blood and the genomic signature of cells that are being shed from an artery into the bloodstream, that would be basically sending a signal to a smartphone, and a special heart attack ringtone would be sounding off, and you'd know days before a heart attack would otherwise occur.
Okay, so let me just, so let's start with sensor in the blood. What is that? Is this? I mean, this is not the pill you swallow. How do you get a sensor into the bloodstream?
Well, this is taking the wearable sensor phase that we're in right now to a kind of uber level of being able to have a window into body's medical essence, because so much is going on in the blood. And so if you can just inject in the vein in the arm a sensor that's about 90 microns right now. We're working with Caltech on their nanosensor group. It will then lodge in a finger, and then basically that can talk continuously, powered by the blood itself, to a smartphone.
Okay, powered by the blood itself.
Right.
Is that like a hydroelectric dam in your bloodstream? Or?
You got it. That's it.
Really? I just invented
you could call it that. It sounds pretty good to me. The power of the blood itself is basically adequate for something that small to provide a power source.
So, and this sensor, 90 microns, there's not a risk of that getting into the heart and causing a blockage or something?
No, it gets down to a kind of watershed capillary bed area, so it really can't go much further than that.
How do you make sure that happens?
Well, we're doing animal testing first, but you know, there's already been some work along those lines. Stanford also has done a microchip floating in the blood. Fantastic voyage, they called it.
Yeah.
So, you know, I think we're moving in that direction. That's a bit futuristic. It's going to be at least a few years before we can really get that enabled in patients. But I think it's exciting because then you could follow free circulating DNA continuously for someone who's had cancer or is at high risk. You can follow antibodies in the immune system to be able to predict an immune attack. So all kinds of things by once you have that type of surveillance.
So what is I just got to understand this. So what is the sensor, how does the sensor, that sensor is able to, I mean, a genetic sequencing machine now is huge, but you're talking about a sensor that's that tiny that somehow can be parsing genetic code.
Well, that's basically an outgrowth of this digitizing human beings. Because if you can get a genomic signature, it could be DNA or RNA, it could be an antibody, you can couple a sensor today to a specific signal. And that...
I see, so it's recognizing a pattern rather than decoding the whole thing.
Yes,
okay.
Exactly.
So those are very tiny, very futuristic sensors. But you are also doing a lot of work right now with sensors that are existent and able to be used. And you brought some.
I did.
So I wanted to go through some of those because those are important because they're actually, even though they're not little sensors that are using the power of our blood in our fingertips, they are very much kind of this step into the future that is this medicine we've been talking about. So I want to go through those. Your choice. Which one goes first?
Well, these are things that we're using today. I'm using in certainly in patients. Like when I see a patient in the clinic, I don't send them for a cardiogram. I can just do it on the phone. So this has a couple of sensors in the back. You make a circuit with your heart and just pop it on the back of an iPhone, or this little credit card version you can use to get the chest leads. So you can do all that. Yeah, it's really
a live core, right? A
live core technology, right? And so you just basically can pull up the app for doing a cardiogram, put your fingers on it, and in a second we should have a cardiogram. And
that's your...
Yeah, that's my cardiogram. You want to do yours? I mean,
I'd love to. I haven't done a cardiogram in years.
So we just, but what's great about it is then you could just set it up, you know, if you were worried about a heart rhythm, that you were worried about...
Now I'm going to...
Just put a finger on
you're going to see something and I'm going to have to go to the hospital right away or something.
There it is. That's good. You know,
see, I'm nervous.
And maybe that was that run this morning with Ash.
Got a deep breath. Wow, that's not good, is it?
No, it's actually a nice pacemaker, normal sinus rhythm.
All right,
there.
good. See, it's going down, yeah. Going down. It was at 90 and now it's at 74. Come on, get down to 73. Okay, I can do this later. But so I want to ask, there's two things about this that so one is you had this great story about when you had that kind of prophetic call on the airplane when they said, is there a doctor on board? And what happened?
Well, I had never even thought of using it, you know, at 30,000 feet. But when there was...
But you had it on you.
I had it because I was at a program like this and was showing it. And then I realized that when this passenger was having chest pressure and I didn't know whether it was indigestion, he didn't know it was indigestion. Maybe I can go get this and do a cardiogram. And actually, it was this part that was the key, because then I could do all the so-called precordial leads in the chest. And that showed a very classic pattern of a so-called anterior wall, front of the heart, evolving heart attack. So there wasn't any question what it was, and that led to getting him to a hospital emergency landing.
So you said land the plane. He's having a...
Well, I mean, the pilot, of course, wasn't too interested in landing the plane, but there was objective data that you know, there's something going on here that is the real deal.
Right.
But the interesting thing about it was, you know, he did well, and they got the ambulance already. But when he got off the plane, the pilots and the flight attendants all wanted to have their cardiogram done. I mean, that was amazing. That was amazing.
So, and before I let this thing go, because this seems like it's out there, but it's not approved by the FDA yet.
Good point.
It is approved. It is approved for veterinarians, right?
Yes.
Or I don't know if
yes.
does the veterinarians have an FDA? Do they? It's just veterinarians can buy it.
Yes.
So there's a lot of savvy doctors who are veterinarians on the web and buying these and then using them off-label, basically, right?
That's what I've been
Allegedly?
getting some physician emails to that effect. Yes. Interesting.
So, all right. So it's we'll let that go where it goes. Okay, but the other ones.
Okay, so this one is kind of neat because yesterday you were talking about glucose and diabetes. So I'm wearing a sensor like this, which has a tiny 27-gauge needle, hair thin, that goes under the skin of my abdomen. You can also wear it on your arm. And so this connects to the phone, and every minute you get a glucose. So if you turn the phone on, it's still 725 in California. But my glucose right at this moment is 98.
So it's non-invasive.
Well, it's very minimally invasive. There is a tiny, but it actually is, you feel it much less than a finger stick.
It's not the needle. It's not the...
It's a prototype, but what's nice about this is you can go 2 weeks really without any finger sticks. You can get factory calibration. It appears to be amazingly accurate, but it's really in many ways an amazing impact on lifestyle.
Yeah.
Because when you're holding your phone all the time doing stuff and then you're seeing your glucose every minute, it has a big impact on what you might eat.
Yeah.
Because you don't really want to see your glucose be shooting up. And this is the future. This is a major, I think, a vital sign that will be on our phones before long. I think it's pretty exciting, and it really does have an impact on your activity, your lifestyle. You learn about certain foods, especially I have learned, that have a marked effect I would never have predicted on raising glucose and leading to a kind of durable hit to your islet cells of the pancreas.
Right. So, and the last one is an ultrasound machine that attaches to your phone. Or something.
Right, right. So this one I use in every patient. I haven't used a stethoscope in a patient since January 2010 when I got my hands on this. Because why would I listen to lub-dub, which I was a big proponent of that, doing a lot of bedside cardiology teaching, but I said, forget that. That's history. Because this basically takes the place of that, because you can do the entire heart exam in a few seconds. So I mean, I can show this to you. I don't want to have you take off your nice tie and shirt, but I'll do that. I'll do a scan of my heart here, just to show you how fast this is done and how much information. I got to put some gel on here, which is a little goop, but and I promise I won't pull an Anthony Weiner. I know that I'm in New York City. But you see, here's the ultrasound, and basically, what I can do is there's my heart muscle,
yeah, there it is.
and I don't know if you can see that, but that's my mitral valve, my heart muscle. Right ventricle, aortic valve, the size of every...
Oh, I see it, yeah.
Yeah. And all that is in the...
I was going to say, it's a boy. But,
you would say that. Now...
And who makes that?
That's a GE.
And that's available
phenomenal device, which I don't know why. Well, actually, in a way, I do know why. But it should be part of the physical exam. Why should you send patients to the formal echo lab, unless there's something structurally really significant? We do over 20 million echoes in this country, $800 each. And most of them are unnecessary. And not only that, but when we use a stethoscope, it's relatively non-informative.
Right.
This should be part of every physical exam. And the other thing that's really phenomenal, when you can digitize a person's heart or abdomen or wherever you're doing ultrasound, that is widely transferable through wireless. So you can have somebody, a paramedic in the field, you can have an emergency room doctor, and send these loops, and you can get interpreted by an expert. All you got to do is be able to put this in the area of interest,
yeah.
and you're golden, because you now are getting this information, shared, and that's, I think, really a great step towards.
Indeed.
Yeah.
All right, we have time for a couple questions. I have one on Twitter to start us off. Are doctors and hospitals? Fair one. Are doctors and hospitals fearing the loss of money through technology-empowered patients? Are they feeling loss of money?
Well, the empowered patient era hasn't really, the real one, hasn't gotten roots yet. I mean, that's actually really why I did the book, is trying to get that moving forward. Because, you know, we're at this point, which I would describe as a medical Gutenberg. Whereas the printing press in the 1400s changed everything, now we have smartphones and tablets with all one's critical information that is now in the hands of consumers. So when that really gets going, and people have their data that they own, as I agree with Rick yesterday, that's the shift that can occur, and that would really propel this great inflection, great shakeup in medicine.
All right, a couple questions up here. Here comes the microphone.
If you had a magic wand, what would you do?
He does have one.
Okay. Let's say the second one. What is, and you walk into medical school today, what would be the first thing that you would change and tell the deans to do?
Well, it's funny you asked that, because here in New York City, Mount Sinai, on the first day of medical school, rather than giving out stethoscopes, they gave out these V-scans to every medical student. And that was a sign of progress. But beyond that, I mean, the problem today in medical schools, I started a medical school when I was in Cleveland, and this is 140 medical schools in this country. Is there any curriculum that really is into genomics today, you know, contemporary genomics? How about wireless sensors? How about, you know, this whole movement of what we're talking about this morning? So that has to change, and it's actually remarkably difficult to change a medical school curriculum. It's kind of like changing the medical community. They're very resistant to those sorts of things. But that's what I would try to do, is basically, you know, reboot education. And it's also, you know, still very traditional with classes and the old way of learning. There's obviously a far better way to do that today.
There's another question right in front.
Art Kaplan.
Testing.
Art Kaplan, the bioethicist who has escaped from Penn, is now here in New York, has always called behavioral health and psychiatric conditions the third rail of bioethics. Where do you see, or do you see, any intersect in terms of genomics interacting with psychiatric or behavioral conditions, and in a way of either addressing them or managing them and monitoring them? Well,
there's an amazing number of interactions that you're bringing up here. Like, for example, just in recent weeks, we learned that these new mutations in sperm, I mean, in fact, I think Craig touched on this just barely, but that's creating much more, as fathers age, neuropsychiatric diseases such as schizophrenia, autism, intellectual disability. We also, by the way of biosensors, have an amazing ability now to quantify mood through an aggregated way of not only galvanic skin response, but inflection and tone of voice, movement, communication. You put all these things together, you can have exquisite ability to quantify mood, to follow people, for example, with depression. So digitizing mental health, both with respect to genomic liability, as well as the physiologic sensor world, is really opening things up. And obviously, this is a really important area.
We have time for one more question. There was one thing, so we have lots of gadgets, but one thing we talked about that I wanted to make sure we touched on was this: it's not all gizmos and gadgets that you're advocating. The Open Notes initiative was one we talked about, which is actually funded by RWJF, but describe that and the impact of that.
Well, I think this is one of the most important studies to come out in a long time in terms of democratization of medicine. And so what Robert Wood Johnson did was fund this Open Notes initiative. Now, even though by HIPAA we have the right to request our office notes, nobody knows that and nobody does it. And physicians don't want that to go out because they say, hey, I've got in my note, it's about SOB, and the patient may think I'm calling them an SOB when it just means shortness of breath. So the whole idea is, oh my gosh, the patients would be terribly insulted and confused. You know, I wrote obese or whatever. And so it turns out in this study of over 13,000 patients in 3 centers, Seattle, Boston, and Geisinger, Pennsylvania, they showed a remarkable impact of how good this was. And in fact, the patients loved it, and the physicians who were doubting about it before going in, they loved it too. So now every one of those individual patients in those centers are getting this open note access, and that's the way it should be across the board.
Did they measure improvement in health, or was it?
They measured particularly things like adherence to medications, about comfort with their whole program of their medical management, whether they were worried or confused, which was like 1 to 8%, which is really low single-digit numbers between the 3 different centers. It was actually really remarkable, and it was a wake-up call that why aren't we doing this? Why don't we have the parity of information and the respect for consumers that they deserve? And this is just part of that medical priesthood, that kind of analogous to the Gutenberg story, which I think we have the opportunity now with this living by numbers and getting the information to the people who deserve to have it, who should own it. That's Open Notes has contributed nicely to that.
Right. Well, Dr. Topol, thank you so much for bringing us into the future of medicine.
Thank you. Thank you.